recently we have analyzed and presented as well as published molecular subgroup analyses of response rates and survival with the hypomethylating agents, azacitidine, decitabine in combination with venetoclax. What we see is that there are certain patients where the responses and survival are very dramatic and very positive. These include NPM1, IDH1, IDH2, and in some analyses, RUNX1. So patients who have one of these underlying mutations seem to have response rates of 85, 90% or higher to the hypomethylating agent venetoclax, and these responses are very durable. With NPM1, IDH1, IDH2, we see that at 3 years, more than 85% of the patients have maintained their response. So these patients have a very high chance of actually being cured, we think, with this doublet combination, which is a low-intensity therapy, outpatient, much better tolerated than traditional anthracycline cytarabine induction. Now, there are also molecular groups that unfortunately do not have as robust or as durable a response. These include TP53 as well as FLT3 mutation patients. And with these patients, interestingly, we see that the response rates are not too bad. They're about 50 to 60%, so a little lower than the 70 to 80% we would see in the general population. But concerningly, the survival, especially with TP53, we did an analysis at MD Anderson, and the analysis has also been done on the large data set that was multinational study, and we see that the median survival for TP53 with hypomethylating agent venetoclax is about 7 to 8 months, which is a little better than we would get with azacitidine, decitabine alone, where it was about 6 months, but definitely much left to be desired. And with FLT3, this is quite interesting. Historically, based on preclinical data, we expected FLT3 to be resistant to venetoclax, and in the single agent study, we did find that FLT3 mutated patients were resistant to venetoclax. In the combination, we started thinking that since the response rate are about 60-65%, maybe we're overcoming it. But again, what we see is that the survival, especially of FLT3 ITD mutated treated with azacitidine venetoclax, is about 10 to 12 months, which again is better than azacitidine alone, 6 to 7 months, but is not ideal, and potentially either adding FLT3 inhibitors or using a doublet of azacitidine FLT3 inhibitor may be better. So these are the areas where there's a lot of research ongoing how to improve azacitidine venetoclax therapy further. In general, in oncology, and the same applies in leukemia, there's always preference for outpatient regimen, lower toxicity, and oral therapy. And venetoclax is an oral drug. Now it's given in combination with azacitidine and decitabine, which are given either IV or subcutaneous, but the nice thing is that these can be given outpatient. They do not require hospitalization and definitely not prolonged hospitalization. So at this time, that is one of the positive features that a lot of physicians and patients like about this regimen as compared to standard induction. Now there is data emerging also with an oral formulation of azacitidine as well as an oral formulation of decitabine. So many of us feel in the near future, in the next 2-3 years, it is possible that we could be having a complete oral regimen, oral azacitidine or oral decitabine with venetoclax. So we could see a new acute leukemia patient, give them 2 pills with close monitoring of blood work, and all of the treatment could be oral and outpatient, which if somebody would have said this 20 years ago would have been unheard of. So this is quite dramatic progress that is happening in the field.